Welcome to Understanding the Clinical Spectrum of Myelofibrosis, Expert Perspectives on Molecular Biology, JAK inhibitors, and Emerging Therapeutics. I'm Surgeon Verstovsek from the University of Texas MD Anderson Cancer Center. Joining me today is Ruben Mesa from Mays Cancer Center at UT Health San Antonio MD Anderson. Thank you to Medical Learning Institute and PeerView for providing this session, and to Bristol Myers Squibb and Insight Corporation, as well as Constellation Pharma, for providing the educational grants for this webcast. Look out for pool questions we'll be asking you throughout this activity. You may want to keep track of your responses. Also, we've prepared some practice aids that we will be highlighting during our discussion. You'll want to refer to them throughout. So please take a moment to download these tools before we get started. During this broadcast, we'll answer some questions that you've already submitted, but we also encourage you to ask questions via live chat throughout this virtual event. Please click the Live Chat tab on your device to participate, and we will be available to answer questions live throughout the session. These are my disclosures. And these are disclosures for Professor Mesa. Here are disclosures for planning committee and content peer reviewers. And finally, disclosures of unlabeled use of the drugs. And a disclaimer. This is an important slide. You see here a website in the upper part of the slides. Please download the slides and practice aids and apply for CME or MOC credit by clicking the buttons located in the left-hand panel. In addition, there is the Twitter information on the right lower part of this slide for you to enjoy the Twitter as well. If you need more information, send an email to live@peerview.com. So welcome, and this is a little introduction to what we're going to do today. We're going to have this particular agenda. It will be in 3 parts. Masterclass number 1 will talk about new thinking on the molecular biology of myelofibrosis, followed by the Masterclass 2 and case forum, where we will describe where we stand with JAK inhibitor options in myelofibrosis. And finally, we will summarize it all with Masterclass number 3 on innovative targets in myelofibrosis and implications for future therapy. So let's start with Masterclass number 1. Ruben?
Thank you very much, Serge. So we're going to kick it off with discussing a bit of our evolving understanding of the biology of myelofibrosis and how that potentially impacts our choices of therapy. Now, before we talk about some of these biological pathways, let's frame what are we talking about with myelofibrosis. So let's look at the WHO criteria, which is the most recent for the diagnosis of primary myelofibrosis. Here there's major criteria. The first is histological regarding megakaryocyte changes as well as fibrosis. Second, and this is important, not meeting the criteria for other disorders. Indeed, there can be sometimes MDS patients that have secondary fibrosis, or there's CML with fibrosis, or there's ET that is evolving into myelofibrosis. So very important, have a good hematopathologist to separate this. And third, and this is important, the presence of one of the 3 driver mutations. We've learned that the JAK2, CALR, MPL present in the majority of these individuals and that they are mutually exclusive. Your diagnosis requires meeting all 3 major criteria and at least 2 of the minor criteria confirmed in 2 consecutive determinations. Now, individuals that lack one of these markers, you could still come up with a diagnosis, but you ideally want at least another clonal marker, or at least be very certain that there is not a secondary cause. So if you're lacking a driver mutation, the burden on you to be certain about the diagnosis really increases. It's additionally important to look at these minor criteria. There's a clinical phenotype of myelofibrosis, anemia, not attributed to a comorbid condition, leukocytosis, splenomegaly, elevated LDH, leukoerythroblastosis. Why is this important? Well, because individuals might have the JAK2 and have ET or PV. They might even have a little bit of scarring or fibrosis. But without these minor criteria, they may not really have the syndrome of primary myelofibrosis. Now, a critical part of diagnosing this disorder is the bone marrow biopsy and the testing. And indeed, the WHO really requires of everyone now to obtain a bone marrow for diagnosing ET, PV, or myelofibrosis. Yes, if you have an increased platelet count and you have the JAK2, that patient might well have ET. But if you've not done the bone marrow, you really cannot be certain that it really is not a patient with myelofibrosis. So you start with that marrow aspirate and biopsy with trichrome and reticulin stain. You do cytogenetics, you do molecular testing, and then there's the conditional, which most labs will do for you now. The JAK2, if that is negative, specifically for the V617F, you will get the calreticulin and MPL mutations, or the exon 12 if you are suspicious of polycythemia vera. Additionally, you may well obtain a next-generation sequencing panel for other somatic mutations, and we'll get around to those in just a moment. As we think about the clinical features of MPNs, indeed, PV, ET, and MF, you see with ET and PV, we have high counts, we have symptoms, we have risk of vascular events. Myelofibrosis, more sinister, more anemia, more thrombocytopenia, leukocytosis, leukoerythroblastosis, splenomegaly, and symptoms. Now, as you look at the molecular profile, you see that there's a similarity between ET and myelofibrosis, JAK2 in a little over half, calreticulin in roughly a third, MPL perhaps a bit more frequent in MF, and triple negative being slightly more common in ET. PV, primarily a JAK2 mutated disease with only a sliver that are JAK2 negative. I would encourage you to download the practice aid for more information on myelofibrosis resources for your patients. Now, the JAK-STAT pathway has really proven to be very important in this. As you see there, the JAK2 V617F impacting really the receptors for erythropoietin, for MPL, for GCSF, and hence the implication downstream in terms of the overproduction of cells. Now, what you'll see as well is that calreticulin and MPL are additional mutations that can occur, but really are impacting the same axis. That is why the phenotype of these diseases really can overlap to a significant degree. Additionally, as we end up talking about therapies and JAK inhibition, it has largely been found that individuals, regardless of which of these three mutations they have, can have relatively similar responses to JAK inhibitors. That is largely because the JAK inhibitors are inhibitors of JAK2. They are not specific to mutated V617F. Therefore, calreticulin, MPL, or V617F mutations are all signaling through that JAK-STAT pathway and hence that shared activity. Now, calreticulin is the most predominant non-JAK2 mutation, and there are some important phenotypic differences, both with ET and myelofibrosis. There may be lower risk of thrombosis with the calreticulin mutation. There may be a better prognosis with the calreticulin type 1 mutations over those with a calreticulin type 2. Increasingly, we're learning more about prognostic significance of mutations in MPNs. So first, as we think of driver mutations, we have patients with either JAK2 or MPL or CALR, and it's notable that CALR mutations, particularly type 1, have improved survival compared to JAK2 mutated or triple negative patients. They also likely have a lower risk of thrombosis compared to the JAK mutation. You see that individuals that are triple negative have an inferior leukemia-free survival and an inferior overall survival compared to patients who are calreticulin mutated. You see 4 mutations there: ASXL1, EZH2, IDH1 and 2, SRSF2. They can have decreases in survival, overall survival, and potentially progression-free survival. We see that combinations can have relevance in terms of prognosis. The combination of CALR and an ASXL1 status. So the longest survival being in those that are CALR positive and ASXL1 negative. The shortest in individuals that are CALR negative and ASXL1 positive. A difference between a median of 10.4 years versus 2.3. And intermediate being the other alternatives, both CALR ASXL1 positive or CALR and ASXL1 negative. Final ones I would mention, ones such as TP53 associated with leukemic transformation. So increasingly, as you see, the molecular profile having more granular impact on prognosis. Because of the tremendous heterogeneity in the natural history of MPNs and in myelofibrosis, there has been significant efforts undertaken to try to create prognostic scores to better guide clinicians in decision making. Globally, the DIPS or DIPS Plus is most commonly used, which does not include molecular features, but increasingly the MIPSS or MIPSS 70, or now the score more specific for post-ET or post-PV MF, have been developed and include these features. According to our current NCCN guidelines, the decision-making still largely revolves around whether an individual is lower risk or higher risk. So you can plug into the score of your preference. I find if I have molecular data, I will use the MIPSS 70 or the most recent version. There fortunately is a website, mipss70.it, I believe. The server is based in Italy, where you can plug in the clinical data, get information. And I think it is the most helpful, particularly regarding decision-making for stem cell transplantation. Now, increasingly, as we talk about new therapies today, I'll highlight for you how these have different impact on the different pathways within the cell that might be involved with the disease. We've talked about JAK2 inhibitors, but you'll see on this slide many other additional agents, IMiDs that impact the bone marrow microenvironment. You have agents that are really having an implication in terms of apoptosis, such as navitoclax or venetoclax. You have agents such as the BET inhibitor that's having an impact on really within the nucleus with pelabresib or CPI 0610. Indeed, you see a variety of different agents really acting within the nucleus from epigenetic modulation. So increasingly, we are trying to have an impact on the disease through a variety of different complementary mechanisms of action. Calreticulin has some interesting implications for the future. Calreticulin can be present on the cell surface, which is different than some of the other mutations in MPNs. And for this reason, there is much preclinical work ongoing regarding perhaps calreticulin blocking antibodies, peptide vaccines, or other approaches. These are not yet ready for prime time, but are approaching the clinic each and every day. So how has this understanding of biology impacted management? As we look at the NCCN guidelines for myelofibrosis, indeed the molecular impact of the disease is all over this slide. First, in terms of assessing prognosis, particularly as we think about the refinement of prognosis with the utilization of the MIPSS 70 or other molecularly driven scores, helping to refine prior intermediate risk with DIPSS. Second, without question, the discovery of the JAK2 mutation has led to the important inclusion of the JAK inhibitors on this slide. The development of these therapies, ruxolitinib, which is recommended in anything really above symptomatic low-risk myelofibrosis, or fedratinib, now for intermediate to and high-risk individuals. I envision as we continue to have more advances in the molecular understanding of the disease and more agents, we will continue to be adding agents onto this treatment recommendation, and we'll be, as we go through agents later in the course of our discussion today, we'll highlight, Dr. Verstovsek and I, where these therapies might fit in the paradigm. Indeed, I'd remind you again to download that practice aid for more information on approved JAK inhibitor therapies. Indeed, as we think about these different therapeutic strategies for trying to achieve disease modification, there are increasing, let's say, themes of mechanisms of action that maybe work alone or in combination. The microenvironment and fibrosis, TGF-beta and others of which we have been working to have an impact over many years. Immunotherapy, undoubtedly immuno-oncology has made an enormous impact upon solid tumors and continues to be tested. PD-1 and PD-L1 inhibitors have not directly been as impactful in myelofibrosis as in other diseases, but that doesn't mean that this strategy may not yield fruit. There may well be calreticulin-directed immunotherapeutic approaches. Interferons undoubtedly work through this mechanism. Proliferative signaling obviously has been the most impactful with 2 approved JAK inhibitors and 2 well advanced in testing, such as momelotinib and pacritinib, which may become available soon, as well as other inhibitors such as PI3 kinase inhibitors that are currently in phase 3 testing. Epigenetic regulators having a big impact. Hypomethylating agents clearly can have a benefit for these patients, alone or in combination with JAK inhibition. IDH1 and 2 inhibitors are current ongoing trials, combining these with ruxolitinib for individuals with advanced disease, BET inhibitors, as well as HDAC inhibitors. And finally, there's a variety of agents looking at the hematopoietic stem cell, maintenance, survival, and differentiation. IMiD drugs have been active here. Telomerase inhibition. So imetelstat has had an impact. We'll hear more about that data and ongoing phase 3 studies with that from Surge, as well as MDM2 inhibitors. So we've come a long way. As I think back to the early 90s, we largely knew very little about the molecular biology of myelofibrosis, and largely were using agents more empirically against the disease than really molecularly driven. We've evolved from initially trying to target JAK2 to trying to target a whole range of different important relevant mechanisms that are involved with the pathogenesis of the disease, the development of difficult symptoms, and other biological features of the disease. So with that, that's a perfect segue for me to hand it off back to my friend Serge Verstovsek to talk about where we are now in terms of our therapies with JAK inhibition.
Excellent masterclass number 1. Ruben, thank you so much. We're going to move on, as you said, to describe where we stand with the JAK inhibitors and where are we heading with the JAK inhibitors, because there are not only 2, there are more. As you see on this slide on the left side, as widely known, we have 2 drugs that are approved, ruxolitinib for about 10 years now in myelofibrosis patients, but also for a number of years now in a second-line setting for patients with polycythemia vera after failing resistant, refractory, intolerant to hydroxyurea, which is standard practice frontline PV therapy. And fedratinib joined 2 years ago with approval of a myelofibrosis indication. As we all know, it joined with a similar activity to what we can achieve with ruxolitinib. So we have 2 drugs now approved for management of myelofibrosis. But where are we heading? We are heading to have soon enough approval possibly of a pacritinib. We expect the decision on its possible approval by the end of this year for patients with myelofibrosis that have low platelets, and this would be platelets below 50,000, for which ruxolitinib or fedratinib are not suggested. They should not be used in patients with platelets below 50, while pacritinib might be active in that area. And there is also a phase 3 randomized study underway for patients with platelets below 50, comparing pacritinib to best available therapy, so-called Pacifica study. Momelotinib, which is second in the middle box, is quite interesting. And I'll come back to momelotinib a little bit later, because it is now being developed as anemia drug. Basically, it can, as we know, with all JAK inhibitors, improve the quality of life, but it seems through special characteristics inhibiting the hepcidin, which is a regulator of iron metabolism, it may improve the anemia parameters. So indication that this drug being developed for is for patients with anemia and bad quality of life, unlike any other JAK inhibitor. And of course, there are ruxolitinib combinations with other agents that Ruben reviewed for us in short order. We're going to talk about this a little bit later a lot. Combinations are being developed for frontline use or for salvage of the patients that are failing ruxolitinib to boost what ruxolitinib is supposed to do or bring additional benefits. And then NA018 is the one JAK inhibitor that has now been revived. There is a study underway, a randomized study, comparing its activity to best available therapy also in patients with low platelets. So we're going to touch upon some of these, most of this, throughout our presentation later on. So let's start with the case and see how we're going to manage this particular case. This is a lady, Katie, which is 73 years of age, important parameter here. She was diagnosed recently, a month ago, with primary myelofibrosis upon her complaining about progressive left upper quadrant abdominal pain and pressure. Upon questioning, she really said that she has that early satiety and she lost a lot of weight and has a night sweating, so bad quality of life. Examination, physical examination, showed that she lost some weight and also slightly enlarged spleen and slightly enlarged liver, some edema in her legs as well. But the most important part here with the blood cell count is that her white cell count, which is normal, was accompanied by very low hemoglobin of 7.9 gram per deciliter and lower platelets at 97,000 with 2% blast in the blood. The workup of the bone marrow showed JAK2 mutation and some other mutations, among which ASXL1 is usually the one that we talk about as a bad prognostic factor. So she has a high-risk myelofibrosis based on a combination of older age, systemic symptoms, anemia. These are three factors in a classic international prognostic scoring system. Even without genetic abnormalities, which is ASXL1, she's already high risk for myelofibrosis, untimely death. So what would you recommend for Katie in the frontline setting? JAK inhibitors, absolutely. I would think we would think about that as an option. And, well, maybe transplant based on eligibility. She's a little bit older, but certainly we would think about that as well. And one would not exclude the other. While we are looking for a transplant, for example, we can help patients with JAK inhibitors. But this particular case brings about three parameters that I'd like to highlight, because we know that JAK inhibitors improve the symptoms and the spleen. This patient does not have a very big spleen, has a lot of symptoms, and is very anemic and thrombocytopenic to some degree. So let's tackle these particular aspects in a little bit more detail. So here is analysis of the JUMP trial. This was more than 2,000 patients treated with ruxolitinib in 26 countries. And what I'm showing here is an analysis of particular patients with particular characteristics. What I'm showing here on the left side is a proportion of the patients achieving a response based on platelet count. This is the response in the quality of life. And quality of life here, as you can see, again on the left side, was achieved in a very good proportion of the patients, even in patients with the low platelets, defined as the platelets with less than 100,000. On the other side of this slide, on the right side, is a proportion of patients with or without the splenomegaly. With or without splenomegaly, meaning spleen was big and present or not at all. And what you can see here is that quality of life improvements was about the same, regardless of the underlying presence or absence of big spleen. So in other words, the spleen size or a presence of big spleen does not matter for achievement of a good quality of life. And to some degree, the same applies to a platelets issue. Moving on to actual management issue. How do we manage patients with low platelets? EXPAND study was published a couple of years ago that further established the different approach to therapy of patients with low platelets. And here we are talking about the platelets 50 to 100. These are that we usually associate with somewhat worse outcome, and traditionally one would use perhaps 5 milligrams, the lowest dose possible, of ruxolitinib twice a day. This particular study gave us further information on ability to manage and achieve good response in these patients, and suggested that we should be starting patients with a 10 milligrams twice daily for both groups. These were two groups, 75 to 99,000 platelets, or 50 to 75. And I would say from my own perspective, if I do start with 5 milligrams twice a day, I am almost always able to go to 10 milligrams twice a day. So it's quite reasonable to entertain a possibility to start at 10 milligrams twice a day from the day one. Now, what about the patients that are anemic? Anemia is more prevalent than thrombocytopenia in the patients that are JAK inhibitor naive, and it may develop more often on the therapy with patients that are receiving JAK inhibitors. 50-50 chance typically to develop grade 3 and 4 anemia, and perhaps about 20% chance to develop grade 3 and 4 thrombocytopenia. So here is a suggestion of alternative dosing regimen of ruxolitinib as a frontline number one line of therapy for patients that need control of spleen symptoms and are anemic already at that point in time. So that study, recently published in journal Leukemia, is quite intriguing. Patients are starting here, like I described earlier on for patients with low platelets. They start at 10 milligrams twice a day. They stay on 10 milligrams twice a day for 12 weeks, which is about 3 months. And then you go up. So you go up from 10 twice a day to 15 twice a day to 20 twice a day, 25 twice a day. I would say the aim is here really during the first 6 months of therapy to get to the maximum safe dose and to benefit patients the most in terms of particularly important degree of a spleen reduction. And with this alternative dosing regimen from low to high, you can see here 56% response rate by palpation, meaning 50% of spleen reduced, which is very good result and appears to be in a safer way, because when you look at the hemoglobin levels over time, they remain reasonable constant, and not too many patients require transfusions. About 40% of the patients actually went up quite significantly during this up titration during the first 6 months, and the result is really formidable. Now, talking again about the spleen response and the survival benefit, because throughout the last 10 years there is a lot of information that spleen response, the degree of a spleen reduction, appears to be guiding us how long the patient is going to live while treated with ruxolitinib. And here is information from a real-world survival analysis from United States-based Medicare claims database, which includes a lot of patients here on federal ground in United States. And the simple question was, for this particular analysis, what is the survival of the patients treated with ruxolitinib or not treated with ruxolitinib that have myelofibrosis? And the first column in the table and the green line in the graph is the survival of the patients before approval of ruxolitinib, before 2011, so up to 2010. And you can see that this actually group of patients has the inferior outcome compared to any other group. So care of the patients that were not exposed to ruxolitinib led to a 1-year survival of about 55%. The next line in orange is the post-approval ruxolitinib unexposed patients, better care, availability of the clinical studies, earlier diagnostic of myelofibrosis. Maybe all these factors led to what we see here clearly, a better survival of the patients starting from 2011 on last 10 years. But with the blue line, we see that application of ruxolitinib post-approval, post-2011, over the last 10 years, those that were exposed to ruxolitinib had even better survival. I say that's extra kick of ruxolitinib for survival benefit. Similar results were seen in Europe. This is impact of ruxolitinib on survival in observational study called ERNEST, European Registry for MPNs. This is ongoing effort to document what happens in Europe with myelofibrosis patients. This is the comparison of overall survival based on propensity score matching to account for similar characteristics between the patients treated with hydroxyurea or ruxolitinib. You can clearly see here survival advantage of ruxolitinib over hydroxyurea. So more information is coming from federal registries, observational studies on that survival benefit, which I would like to see obviously in almost every patient I treat with JAK inhibitors, and it is tied through multiple sources to a degree of a spleen reduction. Now, fedratinib was approved a couple of years ago, so let's not forget about fedratinib activity in patients with low platelets who were either ruxolitinib naive or were previously treated with ruxolitinib. So let's take a look at these particular results as well. In the Jakarta study, this was a frontline study. The JAK inhibitor naive patients were given fedratinib, or they were given, and that fedratinib was at 400 milligrams a day in analysis I'm going to show, or placebo. And the results showed that 47% of the patients on fedratinib 400 milligrams a day versus only 1% on placebo had a spleen volume reduction and had a response. The analysis that I'm showing here in this cartoon is the separation of the patients that were there with the platelets between 50 and 100 and 100 or more. Left and right is comparable here. You always see that fedratinib obviously is much better than placebo, no question about it. But if you look at the fedratinib results, and remember, the dose is always the same, 400 milligrams a day, we see spleen response in patients with low platelets at 36% roughly, versus about 49% roughly in patients with higher platelets. So very good response without any dose adjustments to fedratinib, even in patients with platelets that are lower, platelets between 50 and 100. Furthermore, very recently, there was an analysis of a progression-free survival from that study, the Jakarta study, frontline study, where patients were again randomized between 400 milligrams of fedratinib versus placebo. And you can see here in a curve that there was a quite dramatic difference between the two arms. Obviously, Jakarta study showed the fedratinib to have much better influence on progression-free survival. The placebo therapy was not very good at all in any aspect. And so what I'm therefore concluding here is that further follow-up of the patients on the Jakarta studies perhaps, or ongoing other studies, there are other studies with fedratinib underway, may lead us to conclude that this particular agent may lead to progression-free survival or overall survival benefits as we see with ruxolitinib at the moment. So let's see here what happened with this patient. This patient was given ruxolitinib at 10 milligrams twice a day. Platelets were 97, hemoglobin was 7.9, so not easy patients to treat because underlying low blood cell count. Patient did actually very well, and the dose of ruxolitinib was increased to 50 milligrams twice daily, and that led to quite significant improvements in the symptoms, and the spleen was reduced quite significantly for a long period of time. Now, Ruben, here, what's your perspective on the therapeutic approach in this particular patient? Is this reflective of how things would optimally be done? What actually is happening here? Is there something else that we should be doing or considering in management of this patient?
No, I think in many ways this really is an aggressive case, but it's also a typical case. The older individual has very active myelofibrosis, has higher risk disease without question. And I think that this is a very important approach and clearly was beneficial in this patient. I think there are two other options, not that they would necessarily be better. But one, I think a parallel option that's an important consideration is fedratinib. Fedratinib has been approved since September 2019 for this group of individuals. And there is data that we had presented combined from the Jakarta and the Jakarta 2 study for individuals with a platelet count between 50 and 100,000, showing that one was able to give full doses of fedratinib at that dose or at that platelet level that may have advantages. There's not been a direct comparison between that approach versus ruxolitinib in this group of patients, but it certainly would be an on-label parallel approach in which there's good data that may impact spleen and symptoms. And certainly if this individual had not had an optimal response to ruxolitinib, certainly being able to come in with fedratinib would have been another on-label, commercially prescribable approach. In parallel, as we had discussed earlier, you could certainly consider transplantation in this setting. Now, transplantation in the 70s is very complex. Certainly there are success stories that have occurred. However, there are many reasons that transplant becomes less attractive in the 70s due to comorbidities, frequently due to patient choice. I do find that many patients in their 70s, when really confronted with how rigorous transplantation will frequently decline the option. So I think great that this patient turned out well. I think that this is very illustrative and certainly reflective of the benefits one can see with ruxolitinib. I think, as well as you demonstrated, starting at 10 twice a day, but really trying to increase that dose is important. You know, you and I have discussed this a lot over the years, and I think to some degree have evolved in our thinking. There was a period in time where we were, I think, more modest with dosing. And over time, the data, I think, has helped convince us that dose intensity with ruxolitinib is important for the quality of the response, the degree of improvement in splenomegaly, and that correlation of improvement in splenomegaly likely is a driver of why we have seen a survival benefit. I unfortunately see probably too many patients that are on suboptimal doses of ruxolitinib, and you're neither getting your optimal benefit in terms of splenomegaly or symptoms, and this is largely driven, I think, because of concerns about the cytopenias. So we've learned much over time. I think maintaining good dose intensity, and let's say this individual, you started them on 10 twice a day, let's say they developed further transfusion dependence. I think our data over time has shown that supporting the patient through this process, giving them transfusions if need be, is appropriate and does not diminish the overall beneficial impact the experience by being on the ruxolitinib.
This is a really good addition to the case, and multiple aspects that you covered are very useful, I think, for us all. An addition of ASXL1 to the findings on NGS testing here, certainly in some eyes may be of a concern, as it's usually in my eyes, but this case really suggests strongly, and that is the experience, that the JAK inhibitors and ruxolitinib can overcome bad prognostic factors like ASXL1 and still provide, I would say, a very decent, in these cases more than 3 years, a benefit for the patient. So we should not discount the benefits of a JAK inhibition based, for example, on molecular parameters. Certainly I would agree, when you get that benefit like this, the transplant should be entertained as the possibility. However, the other aspect is patient participation here. This is long-lasting therapy, lasts as long as possible while it's beneficial, in this case more than 3 years. Patient's education, patient understanding of what we are doing, patient participation, patient engagement is, I think, one of the pillars for overall success, as is the understanding of the potential of the medications and the dosing, like you very well described. So I think that is a part that I try to emphasize quite often. Almost always I try to educate the patients as much as possible, and so that part is important for overall success, I think, as well. Now, moving on to see what happens with Kathy. So after these 3 years, there was a worsening of the spleen, there was a worsening of the quality of life, there was the anemia that you envisioned might happen. Anemia is actually a leading cause of eventually stopping ruxolitinib. And the spleen is now bigger than ever, 10 centimeters, and significantly symptomatic, tender. The hemoglobin is low, platelets are low, white cell count is higher, typical progression of the disease. And so what shall we do here? You already kind of alluded that there is a possibility of switching from one JAK inhibitor to another. I'm going to talk about this. And then there are clinical trials with the new medications, other JAK inhibitors or other medications that we're going to review briefly for you. Not all of them, but just examples. And the transplant is always an option, although, as you pointed out very well, I would entertain transplant when the patient is doing the best in terms of response to JAK inhibitor, not in a situation like this when the patient has no benefits of JAK inhibitors anymore. So let's review some of these new therapies. To set the stage, I just have this information first. Not only that the quality of life deteriorates, the spleen grows, the numbers may be lower, the anemia and thrombocytopenia are more prevalent in second-line setting. The life is short. And here is the one experience from academic center showing the influence of the platelets on the left side on overall survival. Platelets above or below 100, patients with lower platelets, average survival is somewhere about a year at best. Patients with higher platelets, perhaps a little bit longer, maybe up to 3 years. And additional information that goes with what you were saying earlier on about biology of the disease. Biology of the disease many times means acquisition of other mutations. If you look to the right side, clonal evolution leads to untimely death, where there's no clonal evolution on a follow-up. So there are parameters clinically relevant or biologically relevant that affects the overall outcome. So what can we do? And here is the NCCN guideline. This is for the high-risk myelofibrosis patients, like these patients. We were spending time so far talking about the first box, the red box, which is the non-transplant candidate. This patient was not at the beginning transplant candidate. She received ruxolitinib, but as we all see, ruxolitinib or fedratinib or a clinical trial, and I would say trial that combines something with those agents, are suggested. And now we are crossing over to the right side with the no response or loss of response box, which is then suggesting clinical trial or alternative JAK inhibitors, like in this case possibly might be fedratinib. So that's the NCCN guidelines as listed currently, version 2, 2021. So what happens here with the fedratinib? Fedratinib has a chance of a significantly benefit about 30% of the patients by massively decreasing the spleen and improving quality of life in a second-line setting. And the information showing here is that certainly may have a potential. We'll have to follow these patients more or look at the currently ongoing studies, like in a frontline setting, potential for prolonging life through control of the inflammation and proliferation, decreasing the spleen, improving weight, and eliminating those troublesome general systemic symptoms. So suggestion again from clinical activity to lead us to perhaps somewhat better overall survival in a second-line setting, something to explore in much more detail in the future. Now, momelotinib, I mentioned earlier on, is being developed for anemia and improvement in quality of life. And the anemia is through suppression of hepcidin, through inhibition of the receptor called ALK2. But to give a good perspective on this possible activity on anemia and quality of life, we do need to look back and briefly just remind ourselves about the results on the phase 3 studies that were done in the past with momelotinib. Here we have a Simplify 2 and Simplify 1 study. Simplify 2 study was patients that had intolerance judged by lowering the blood cell count or requiring transfusions to ruxolitinib. In this setting, patients were then randomized to receive momelotinib or best available therapy, which most of the time was still ruxolitinib. In that setting, that's the first line in the table, Simplify 2. In that setting, there was about the same control and modest control of the spleen, no difference. And there was quite an improvement in TSS, which is total symptom score, with momelotinib and not so with best available therapy. So highlighting here improvement in the symptoms in a second-line setting with momelotinib, total symptom score. The Simplify 1 at the lower part of the slide is the frontline study that compare momelotinib to ruxolitinib, where the control of the spleen was the same, Non-inferiority was aimed for and achieved, but the quality of life was not as good with momelotinib comparing to ruxolitinib. So non-inferiority was not achieved, and that's why the study failed. But again, it has potential in a second-line setting to control patient symptoms. It's not bad in a frontline setting at all, and it has potential to control the spleen in frontline setting to some degree. But that led to analysis of anemia benefits. And the anemia benefits was quite interesting. You see the response rate on the right side. This is transfusion independence during the first 6 months of therapy, which was quite different. This is nominal p-value of less than 0.001. That was the third aim of the study. It was actually significant, but nominal because the prior two aspects of the study did not make it. You can appreciate the benefit, though, and you can appreciate the durability of that transfusion independence, which is ongoing. These patients are still many on the momelotinib, and this is very valuable for us to understand. The same also in the second-line setting, Simplify 2. You can see here on the right side, landmark analysis at 24 weeks, transfusion independence, 43 versus 21%. Quite important for the second-line setting, and that durability, again, is shown here, very durable over a prolonged period of time. So we can say anemia benefit seen in frontline and a second-line setting better than controls, better than ruxolitinib frontline setting, with very good control of the spleen and the symptoms, as I showed that before from the Simplify studies. What was shown most recently is from Drs. Mesa here. He may comment later on this. This is the connection, which is not really surprising, that patients that became transfusion independent may have a longer life expectancy. This connection makes sense. The anemia and transfusion requirement is somewhat bad prognostic factors, and these improvements may lead people to live longer. Further work to follow. The pacritinib is a drug that is being studied for patients with low platelets, below 50. There were a number of studies done so far showing very interesting results in a ballpark of about 18 to 20% response rate for the spleen, 25 to 30% response for the symptoms, and it's particularly active in patients throughout these studies in those that have a platelets below 50, and this is where the development of this drug is. In this PERSIST study, the sub-analysis to highlight really these results in a red color in the table showed that, as expected, best available therapy has no activity, really nothing you can do, where the pacritinib, you can see in a table with the red color, platelets below 50, that group had a 23% response rate in the spleen and a 27% response rate in the symptoms. Very valuable responses for patients that have no other options whatsoever. And then to come up to what's happening with Kathy, our patient, 73-year-old, now 3 years older, so much older actually. The transplant may not be an option. She's not in good shape. What shall we do here? Switch to other JAK inhibitors? I would say fedratinib is here certainly a big player. It's suggested by NCCN guidelines, supported by the Jakarta 2 studies. It may prolong life of these patients, but there are clinical studies with alternative JAK inhibitors, as I showed, or JAK inhibitor-based combinations that we're going to shortly review in next segment of today's satellite symposium. Transplant-based eligibility is always, again, possibility, but preferred, particularly older folks, when they have the best response to JAK inhibitor, not when they fail, like this case. So to summarize where we see a positioning of JAK inhibitors in the future, if we look at the right side and the left side, this is the first-line therapy. We have ruxolitinib in the middle of the first line as the standard practice for patients with platelets above 50. Fedratinib is joining now, so ruxolitinib or fedratinib. The platelets numbers matter, less than 50. Pacritinib is coming along. If it gets approved, that will be the niche for pacritinib use for sure. I think the guidelines might be just like that. And for RBC transfusion dependent, perhaps if the momelotinib makes it really in the ongoing study and proves valuable for control of the anemia and symptoms, it may be valuable as a first-line choice in selected group of people that particularly are affected by the anemia. For the second line, we have more diversity, pacritinib again for low platelets, fedratinib for second line in people with big spleen but good bone marrow reserve, and for anemic patients, momelotinib. However, on top of that, we have a number of JAK-based combination therapy in a pipeline. We're going to be talking about this briefly in the next segment of today's discussion. Let's move on with the masterclass number 3. And Ruben, please introduce us to innovative targets in myelofibrosis of interest.
Well, Serge, that was a wonderful discussion regarding where we stand with JAK inhibitors. A lot of relevant points as we talk about new therapies. And you raised a very important point as it relates to that of stem cell transplantation. Indeed, when I share the discussion of treatment planning with patients with myelofibrosis, it's always a balance between transplantation, which is a curative but complex option, and medical therapy. And both decisions really kind of are always existing in parallel. I think we've clearly found that transplantation is an option that can salvage a patient with myelofibrosis, but it probably is most effective if we do it before the patient is too advanced, and that it's done during the interval of an optimal response, whether that be frontline, whether that be second line. That the ability of transplant to salvage an individual who's rapidly progressing is less. So that is an important piece. Indeed, as we even see new options, individuals that still have a transplant option may be best off transplanted when we have an optimal response. So let's talk about some of these new options. Well, first, one that really is exciting is one having an impact on that difficult issue of anemia. An agent both you and I have been involved with now for many years, luspatercept, a TGF-beta ligand-trapped, an agent that's now approved in myelodysplastic syndromes and hemoglobinopathies, is a natural for consideration in myelofibrosis. And there have been earlier phase 2 studies that have demonstrated benefit, either alone or in combination with ruxolitinib, perhaps more robust responses with patients receiving ruxolitinib, as well as individuals that were not transfusion dependent or transfusion dependent. So again, you'll see the greatest response rate for those individuals not transfusion dependent on ruxolitinib. But again, an exciting drug having activity. We look forward to learning more, particularly from the ongoing phase 3 trial. Additionally is the agent navitoclax, a cousin of venetoclax, working as I had discussed earlier in terms of the molecular biology regarding the apoptosis issues in myelofibrosis. Indeed, early on in my career, I had worked in the laboratory of Dr. Scott Kaufman, and we were working on issues of apoptosis in myelofibrosis that can be aberrant. This was an add-on study for suboptimal responders where navitoclax helped to overcome ruxolitinib resistance and resulted in patients having improvement in splenomegaly. Here you see improvements in spleen volume response, really in 43%. This is partial responders who then went on to have a very nice response. Additionally, there was evidence in 25% of improvement in bone marrow fibrosis, so perhaps some incremental sense of activity with a combination. Additionally, this efficacy was observed in populations with high-risk molecular features. And this is pretty exciting. This has been a more difficult group. They sometimes have had lower response rates in clinical trials with single agents. In terms of toxicities, the agent can cause thrombocytopenia or GI-related side effects. The most common, more serious toxicities that were managed around was in particular cytopenias. Usually it was manageable with dose modifications. Now, the baseline mutation status for these individuals going on clinical trials did lean fairly heavily toward higher risk situations. 52% had 3 or more mutations. You see the JAK2 mutations present in 79%. You see the high variant allele frequencies. You see that high molecular risk mutations were in 58% of patients, including many with ASXL1 or SRSF2 mutations. So this was a fairly aggressive disease in this group of individuals that were enrolled. That being said, benefits were seen. Additionally, when looking at secondary endpoints in terms of improvements in inflammatory cytokines, there was a direct correlation between changes in spleen volume and improvement in myelofibrosis-associated cytokine levels from baseline. Additionally, these included several cytokines listed here that we had previously reported to be associated with myelofibrosis-related symptoms and improvements in the overall total symptom score. So nice seeing this strong correlation, not only symptomatic improvement, but really being tied to the underlying biology of the disease that these individuals are experiencing. Pivoting, there is great interest in targeting BET, and BET having an impact really on the nucleus, having impact on increased cytokine production that leads to inflammation, extramedullary hematopoiesis, bone marrow fibrosis, cytokines that have been previously demonstrated to be involved with both the pathogenesis as well as even a decrease in survival with increases in IL-8. There can be aberrant erythroid differentiation and aberrant megakaryocytic differentiation. So with the agent pelabresib, the BET inhibitor, there can be suppression of cytokine production, promotion of erythrocyte differentiation, so hopefully for improvement in anemia, and a normalization of megakaryocyte differentiation. So hopefully really having a range of different mechanisms on the pathogenesis of the disease that you can see why it would be potentially complementary to JAK inhibition. As is seen from this data from the phase 2 study, both from the conversion from transfusion dependent to transfusion independent, that occurred in 34% of individuals, which is a very meaningful improvement, particularly in that difficult milestone. You'll see here in the waterfall plots improvement in spleen volume, but in those with the red arrow, those are the individuals that converted from transfusion dependent to transfusion independent, showing that potential for that significant anemia improvement across the spectrum, including across a different spectrum of baseline levels of splenomegaly and degrees of improvements in splenomegaly. On this slide with the CPI 0610 study, we're looking at spleen volume change in the non-transfusion dependent cohort. Here you see improvements in the spleen. There have been improvement in symptoms as well as there can be improvement in anemia. Again, I would encourage you to download the practice aid for more information on ongoing trials for emerging therapies in myelofibrosis. Serge, why don't you walk us through IMG 7289?
If we are excited about the BET inhibitor, which is bromodomain inhibitor, pelabresib that you talk about, as epigenetic modifier, this is what actually does. Expression of the genes is affected in the bone marrow, leading to all these possible biological activities and clinical benefits. There are others, like LSD1 inhibitor IMG 7289 or bomedestat. This one would be plausibly work in a similar way, having, as you see on this cartoon, effect on malignant hematopoietic stem cells, which would then not lead to the activation of megakaryocytes, which would not lead to enhancement of the growth factors and fibrosis in the bone marrow, and affecting that process of differentiation and inflammation of different cells and the presence of cytokines in bone marrow would plausibly decrease the bone marrow fibrosis, decrease the constitutional symptoms, and that leads to clinical benefits of improvement of blood cell count, improvement in quality of life, and possibly even decrease in the splenomegaly. So there is a very good solid reasoning why this LSD1 inhibitor, as it's the case for BET inhibitor and other epigenetic modifiers, they would work in patients with myeloproliferative neoplasms and myelofibrosis in particular. So What happened in a study? This is a phase 2 study of bomedemstat in the second-line setting in people who were previously treated with the JAK inhibitor. That would be ruxolitinib. In that setting, looking at the quality of life improvements here on the left side after 12 weeks and on the right side after 24 weeks of therapy, you can see how things improve. People already feel better, and that is in a good proportion of the patients at 3 months, and that is seen also in patients who do reach 6 months. So I would be very interested in pursuing that particular benefit of bomedemstat because, look, 24% response rate, that's 50% decrease in the symptoms by 3 months and 31% decrease by 6 months. It's very good, not to mention that there are not too many therapies that you can give in this population of the patients. Now, on the spleen side, the result is a little bit more modest. This is the spleen volume reduction in the waterfall. The spleen does go down in a great majority of the people, reaching a 35% in a smaller group of people, only one patient actually in this slide. This is the how the definition of response is, but nevertheless, the activity is here. Further workup is necessary to understand who is benefiting more than the other and define the group of patients that would be subject to the next step in the drug development of this drug. Therefore, like you showed for navitoclax in the past, understanding the biological correlates is key. Here is the, in a very small print though, but still what is important on the right side, the effect on the mutations. And what it says here, as you see, 44% of the patients showed a decrease in allele burden in the mutations that are present by and large in these patients. They are always present in advanced cases, or there was no worsening much at all. 9% of patients have increased allele burden. So there are biological correlates that needs to be analyzed and possibly tied to the clinical benefit. Imetelstat is another interesting drug that is being developed no less than in a phase 3 randomized study for possible approval in patients with myelofibrosis. So let me just tell you briefly about the phase 2 study experience. This was a study that was comparing head-to-head two different doses of imetelstat, a lower dose and a higher dose. Higher dose is 9.4 milligram per kilogram in a second-line setting. By the way, imetelstat is telomerase inhibitor. Telomerase is an enzyme that maintains the ends of the chromosomes with each the separation of the cells, with the growth of the cells, multiplication. The cells do lose a little bit of DNA, and if that is not corrected, they would die through the loss of DNA. Telomerase is the enzyme, key enzyme in that ability to maintain the chromosome endings, and if you will possibly with imetelstat inhibit it, that would lead to a loss of ability to live, and the malignant cells would die sooner rather than normal cells. So in this study, giving this medication imetelstat IV every 3 weeks, the higher dose, 9.4 milligram per kilogram, led to a median overall survival of close to 30 months. In addition, there were a significant number of patients with some bone marrow fibrosis decrease or improvement. And as I showed for other drugs, also in this study, there was the reduction in a driver mutations in a number of patients. 42% of the patients had that as well. Now, on the clinical part, what you see here is the improvement in the spleen on the left side. There were some patients with a spleen reduction, comparing between the two arms much better in a higher dose, 9.4, which is dark blue. And there were patients with improvement in quality of life, which is on the right side in lower panel. Again, much better with 9.4 milligram per kilogram. So based on this type of results, suggestive of a prolongation of life, suggestive of significant biological activities and decent clinical activities, we have underway a study which is comparing in the second-line setting. It's called IMPACT study, comparing imetelstat higher dose, 9.4 milligram per kilogram, IV every 3 weeks, to best available therapy, excluding JAK inhibitors. People already failed that JAK inhibitor. This is to prolong survival. This is the first time ever that we have a study and it's improperly placed in a second-line setting at the moment, to see whether we can not only control what is immediately needed, control the spleen and symptoms or anemia, but to extend the life of the patients. Of course, we want to know whether symptom response or spleen or anemia response are seen, and that will be looked at as well in parallel. But the number one goal is to prolong survival of the patients. So quite innovative for us, I would say, in MF field, because nobody else so far dared to do the survival study, and we are all excited to join the effort to see whether this is really true and have that drug approved in this future for our patients in a second-line setting. So moving on to kind of an overview of what we showed, and of course we did not show all the studies that are happening or all the medications that are being developed. I mean, Ruben mentioned that there is a phase 3 study in frontline setting with the BET inhibitors, pelabresib, CPI 610. There are 2 phase 3 studies with navitoclax, comparing it to ruxolitinib alone, combination of navitoclax and ruxolitinib versus ruxolitinib alone in frontline setting. And then there is a phase 3 study in the second-line setting. So phase 3 study with luspatercept, a lot of studies. Please, everybody, join the effort, and let's get these studies finished soon and get new drugs approved if we can. But let's, Ruben, you and I talk a little bit about what this slide talks about, gaps that remain in myelofibrosis therapy. And that extends from, hey, how do we improve the spleen symptoms or anemia? Now how do we improve the survival? But let's talk about the role of mutations. How much or how significant that mutation profile really has, in your view, for selection of therapies now and for the future?
Well, I expect it to have an increasing role as we evolve into the future. You know, many of these mutations were found long after the phase 3 studies for the agents we use were concluded. So I think with the big number of phase 3 studies we have at the moment, the correlative studies are going to be very important. You know, I think increasingly we may find that there might be slightly different profiles for the patients that optimally benefit from ruxolitinib frontline, or adjusting the dose, or whom for fedratinib, or might we be able to carve out who has the highest likelihood of response to a momelotinib or pacritinib. I do suspect that we will evolve to patients largely being on an optimized JAK inhibitor, and then likely in a subset a second group of therapies. You know, I think the molecular features may as well help to determine in whom does the intensity of 2 drugs from the beginning, both in terms of either toxicities and certainly in terms of expense, you know, merit beginning with 2 therapies. So I think we will do a lot more than we're doing at the moment. At the moment, it primarily is driving risk scores and the decision for transplantation. But I think it will provide more granularity regarding choice of medicines, dosing, and switching of medicines.
And we should probably expect in the near future that we move on from the molecular signatures to something else. Like in a second bullet in this slide, it's suggestive of cytokine profiles possibly also affecting the choice of the therapy, or I would suspect even the cytokine profiles that might be done during the therapy with some of these drugs that affect the cytokine profiles. We may have a clue who is going to be responding to a great degree or not, and for how long or not. So I think that we should think in the future about expanding horizon from genetic testing or molecular biomarker determination to perhaps looking at the cytokine profiles and perhaps some others to optimize understanding of each therapies, and not only before you begin, but during the therapy as well. So disease modification therapies are certainly coming up. We are doing a lot of correlative studies, understanding what does this all mean, and I hope that this promise of disease modification really pans out over the next few years through what you just described, how that would be guiding what we do in our everyday management. Particularly for, and the last bullet here is the one that identifies the worst case for the patients, refractory to JAK inhibitor therapies where we don't have too many options. I think this is still area of unmet need, number one. Wouldn't you agree?
Without question. I think we still have much opportunity, but, when I reflect on the discussion we've just had, I'm incredibly hopeful for our patients in that, the sheer number of therapies being developed, the combinations, the data is impressive. I think as well, I like to frame it that it's really further disease modifying. I saw a patient this week who's been on ruxolitinib for 12 years. Here's an individual that likely would have passed away from their disease many years ago without that therapy. And your own data really helps to show this. And now we're seeing similar data with fedratinib, with momelotinib, with imetelstat, and have little doubt that similar data will come forward from pacritinib and others. So I think we've achieved some degree of disease modification, and in some patients it's been significant, but I think we could even take it to the next level, and make it more reproducible, because some patients have had those great experiences, but it's not been universal. So I think we'll have much more guidance in terms of how to adjust for the patient that doesn't have that great response, or perhaps better predict which patient is going to have a great response with which approach.
Wonderful discussion. Thank you so much, Ruben, for today's engagement with me. I hope that the audience had appreciated what is happening and how much is happening in MPN and myelofibrosis in particular. We are open for a lovely discussion now with the question and answers from the audience. Everybody, please stay on. I hope you enjoyed it and it's useful for everyday practice and for future planning, what we're going to be doing and what you're going to be doing with your patients with myelofibrosis in the near future.
So our first question is a good one. Are there any lifestyle modifications that you recommend to patients with MF, such as diet and exercise? This is a frequent question from my patients. Well, indeed, we have learned, and there's been a lot of research done by collaborators interested in MPN symptoms and quality of life, to try to answer the question, what else in addition to optimizing medicines can patients do? One, we have found without question that patients on structured exercise, clearly appropriate for them in guidance with their physicians, can be beneficial. It can have an impact on fatigue. It can help to increase oxygen carrying capacity, and almost regardless of the stage can be beneficial. But it needs to be structured and appropriate for them. Additionally, people ask about diet. I think anyone on a structured diet probably is somewhat better off. They're watching volume, they're watching the composition of the diet. Certainly the Mediterranean diet is the most commonly recommended. It's a healthy diet. Patients usually feel better on that. There certainly are exceptions. There have been people who have felt better with every diet you can envision, from gluten-free to keto to others. But I would recommend the Mediterranean diet unless of some other medical reason for guiding that. Finally, our group has been involved with everything from yoga to meditation, beneficial data with each of these, and would advise you to look into some additional information on this, both for the MPN Quality of Life Study Group as well as with the MPN Research Foundation.
The next question is how to mitigate side effects of ruxolitinib if decreasing the dose does not work. And primarily, obviously, we are talking here about the myelosuppression. Anemia and thrombocytopenia can happen and commonly lead to a decrease in ruxolitinib dose. In fact, studies show that 70% of the patients, when started with the standard dose as per prescription, have to decrease the dose during the first 4 months of therapy. Now, how do we go about helping patients that need to reduce the dose and perhaps not benefit from dose reduction? Is by adding another medication. Typically, I would not even wait for significant anemia to develop. I would, when I see the presence of anemia, introduce an anemia drug. The guidance, even the NCCN guidance suggests so, like erythropoietin stimulating agents or danazol or low-dose thalidomide occasionally even a 3-month short course of a prednisone in my own practice. This is not to say that we don't need any new therapies for anemia. There are clinical studies underway where, for example, luspatercept is being developed as anemia drug on top of ruxolitinib in patients who are developing anemia while on that JAK inhibitor. So combination strategies. For low platelets, unfortunately, there is no good combination partner at the moment. Perhaps, and I should evoke the ongoing study results of a combination of ruxolitinib and thalidomide, 50 milligrams of thalidomide daily. It seems that in that study, that thalidomide addition may improve the platelets in 3/4 of the patients. Perhaps then look for the studies. Look for the studies and try to implement proactive anemia drugs or combinations that would help patients from developing these complications that will lead to untimely discontinuation of therapy, and that would certainly have the impact on overall survival of the patients.
Third question, what are treatment options for JAK inhibitor failures? To some degree depends on how one defines the failure. I first always question whether we've optimized the JAK inhibitor we've used. Have we given it enough time to work? Has it been used in sufficient dose? Have we been overly reactive to an initial anemia and not supported the patient during that time? But let's say there has been a failure. After a sufficient dose, sufficient amount of time, there was benefit and then it was lost. So first, I will consider certainly fedratinib as a second-line therapy. The Jakarta-2 study has demonstrated that we clearly can see benefits for the use of that in the second-line setting for individuals. Additionally, if that has been tried and is not successful, we always consider clinical trials, many of the agents we've discussed here today. Alternatively, if we're primarily thinking about anemia and there's benefit in other areas, I wouldn't really call it a complete failure, but would consider the addition of other agents, EPO, danazol, or perhaps in the future luspatercept for these individuals. Finally, individuals moving towards acute leukemia, I think we shift gears slightly in terms of the agents that we're considering and include hypomethylation strategies in addition to JAK inhibition or other trials for accelerated or blast phase myelofibrosis.
The next question is how to best sequence medications, JAK inhibitor or JAK inhibitor-based combinations, especially in frail or elderly high-risk patients. This is a really good question because remember, the typical age of the newly diagnosed myelofibrosis patients is in mid-60s. So there are a number of patients that are older than 70 and older than 80 even. And the disease progresses over time. So patients in a second-line setting, as we discussed, are worse off than in frontline setting. So one would certainly consider in frontline setting JAK inhibitor, no question about it, for control of the spleen and symptoms, and adding anemia drug for patients that are borderline for anemia or already anemic at the beginning. Starting with the lower dose of ruxolitinib, as discussed earlier in the session today, makes sense because starting lower is safer, and so building dose from low to high rather than starting very high and then decreasing is alternative option. In overall, the goal would be to provide the therapy in a safest possible way, particularly older or fragile patients, and combinations of the agents that we have would be entertained earlier in the therapy rather than later. In the future, as we developed, and hopefully we will in a timely manner, combinations of other sorts with those investigational agents, perhaps we will find through biological examinations of certain markers which group of patients would be more amenable to combination strategy upfront than the other. Combination strategy with navitoclax or combination strategy with a BET inhibitor pelabresib. This is hopefully the way we're going to develop the medications in the future based on certain parameters and then having a best possible combinations for the particular group of the patients.
Fifth question. At the beginning of treatment for patients with severe cytopenias and transfusion dependence, how do you start the treatment? Well, here I think it depends on which treatment we're discussing. With ruxolitinib, we know that by product label, under a platelet count of 100,000, we will start at a lower dose and then try to increase the dose. So whether 10 twice a day, or if the platelets are low enough, 5 twice a day. The important part there is to really try to progressively increase the dose over the subsequent weeks, after 8 to 12 weeks, to try to optimize response. And that during that time, if they require transfusions or support, do so, but do not be overly quick to decrease the dose. Now, other therapies, we may well be able to start at full dose at different levels. So fedratinib can be given at full dose for a platelet count between 50 and 100,000. If pacritinib becomes approved, it may well be able to be given at full dose despite thrombocytopenia. Momelotinib might have a similar impact in terms of full dose in the face of anemia. So I think it will depend a bit on which therapy, and will continue to be an evolving issue, but I would follow closely the continually updated product label for the medication in question.
Please remember to complete and submit your post-test and evaluation for CME or MOC credit. If you missed anything, please go to the website, download the slides and practice aids by clicking the buttons located in the left-hand panel, watch the replay of this event, or join the conversation on Twitter, as you can see here. And I want to thank you on my behalf and the behalf of Ruben. Thank you so much for your participation, and have a good day. Thank you, Ruben.
Bye-bye. Thank you.